We will discuss management of painful diabetes neuropathy. This is a very common problem. Indeed, 25% of diabetes patients present with these sort of pains. Let's understand this diabetes neuropathy. This is educational video for healthcare professionals. Patients are advised to seek professional help, and there is no advertisement for any brand or company. In this video, we'll discuss symptoms and signs of diabetes neuropathy. We will see how to rule out other causes, how to choose a particular drug for treating neuropathy, and treatment table or treatment flowcharts. Symptoms and signs. So symptoms and signs depend upon the type of the fiber involved. So if it is a small myelinated nerve fiber, the function of these fiber is pain and protective sensations. Symptoms will be a burning sensation, electric sensation, or stabbing sort of pain. It is diagnosed clinically with signs like thermal discrimination, like cold and hot discrimination, that will be reduced or absent. Pinprick sensation will be reduced or absent. Large myelinated nerve fiber, the function is basically pressure, balance, position sense. Symptoms will be numbness, tingling, or poor balance. Signs will be vibration perception will be reduced, and we check vibration with the help of a 128 hertz tuning fork. A 10-gram monofilament test. This is one of the tests which is underutilized in the clinics. So 10-gram monofilament will test the pressure sensation. It will be reduced or absent. It is checked in the feet. Proprioception will be reduced or absent. This is the clinical assessment of a patient presenting to us with diabetes neuropathy. But we have to rule out other important causes of the neuropathy because the treatment will be different. Other important causes are thyroid disorders like hypothyroidism and CKD patients, systemic vasculitis, multiple myelomas, amyloidosis, infections like HIV or hepatitis B infection, chronic inflammatory demyelinating polyneuropathy, B12 pyridoxine and thiamine deficiency, alcohol intake, drug intake like amidron, colchicine, heavy metals like arsenic or mercury. So in this list, the important causes are highlighted, that hypothyroidism, CKD patients, deficiencies of vitamins, and alcohol intake. These should be kept on priority because the treatment depend on the replacement of these deficiency or treating hypothyroidism or alcohol cessation. Coming to the treatment options are only and only the medicines, because there is no evidence which goes in favor of glycemic control or lifestyle modification as the treatment for neuropathy in diabetes. Though glycemic control, lifestyle modifications can prevent neuropathy, no doubt about it, but once neuropathy occur, these modalities are not effective. So only option left is pharmaceutical interventions. These are the literature to support this statement. The drugs which are available with us are gabapentinoids like pregabalin or gabapentin, SNRIs, that is serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, or sodium channel blockers like valproate or the anti-epileptic medications. Opioids or local agents can be used. So this is a list of the agents available for treating the neuropathy. Now coming to the gabapentinoids, so pregabalin is one of the first line drug which we use. Initial starting dose is 75 milligrams per day. Now how to give this drug? Textbook will not mention practically at ground level how should we advise the patient about pregabalin and when this drug should be taken. One of the most important side effect of the pregabalin is dizziness or slight drowsiness. So the timing is important. Patient should take this this medication in the evening time so that the next day morning hangover will be less. So we usually start with 75 milligrams per day, and every 1 to 2 weeks we keep on titrating the dose till we reach the effective dose. The effective dose of pregabalin is 300 to 600 milligrams per day. Side effects like dizziness will be there, peripheral edema. This is quite common in diabetes patient. Patient will start complaining of weight gain and pedal edema. Other important side effects, there can be suicidal thoughts or seizures after rapid discontinuation of pregabalin. So we have to select the patient ki if patient is having already a seizure disorder or patient is having suicidal thoughts earlier. So we should avoid giving pregabalin. Or patient has a CHF, heart failure with reduced ejection fraction. So this can worsen heart failure. So we should be avoiding pregabalin. Gabapentin, initial dose is 100 to 300 milligrams per day, and in clinical practice, it is seen that gabapentin has more side effect of drowsiness and dizziness. Effective dose will be 900 to 3600 milligram. Again, the up titration will be done every 1 or 2 weeks, depending on the patient response. Side effects are similar to pregabalin. It also lead to, though rarely, but can lead to Steven-Johnson syndrome. Now, these adverse side effects are more severe in older patients. So, in elderly individuals, we should avoid giving gabapentin. Now, SNRI, that is serotonin norepinephrine reuptake inhibitors, duloxetine. This is also one of the first line drug which we give for diabetes peripheral neuropathy. Initial dose is 20 to 30 milligrams per day. Again, because of its side effect of drowsiness, we gave this drug at dinner time or just before the dinner. Effective dose is 60 to 120 milligrams per day. Side effects are dry mouth or decreased libido. Patient can have hypertensive crisis. So if a patient has uncontrolled hypertension, avoid giving duloxetine. Hyponatremia can be a side effect of this medication. So if patient has already have a tendency of low sodium, so avoid giving this drug. So we have to choose the patient according to comorbid conditions. Side effects more in elderly. The next SNRI is given in an initial dose of 37.5 milligrams, and the side effects are same as duloxetine. Tricyclic antidepressants like amitriptyline, nortriptyline, these are given in a dose of 10 to 25. So all these medications have a similar dose profile, and this is given at bedtime. Effective dose is 25 to 100 milligrams per day. Again, it has to be up titrated. Side effects include drowsiness, cardiac arrhythmia. This is one of the important concern. It can lead to prolongation of QT interval, cardiac arrhythmias can occur, conduction disturbances can occur. So if a patient has already a tendency for long QT, avoid giving these drugs. Myocardial infarction rare but possible. Heart failure exacerbations can also occur. A risk of stroke is there. Orthostatic hypotension, seizures can occur because of these medications. Hepatotoxicity, and urinary retention and suicidal thoughts. Therefore, these drugs will be given very cautiously in a patient with a known or suspected cardiac disease. And nortriptyline is preferred over amitriptyline in elderly patients. So amitriptyline is for adults or young patients. Sodium channel blockers, anti-epileptic medications. These are the doses. Again, they will be started in a low dose initially, then up titrated to the maximum dose. Tramadol. These are opioids for pain relief. Tramadol is a very commonly used drug. Initial dose will be 50 milligrams per day. Effective dose 200 milligrams per day. Side effects will be headache, constipation, and seizures. This is a cream that is a local application. This is given in the form of a cream on the feet where patient need desired effect for burning sensation. 4 times in a day it can be used. Side effect will be burning sensation at the application site. Not recommended acupuncture, alpha lipoic acid, or acetyl L-carnitine. We have seen so many prescriptions of these medications for the pain relief in diabetes neuropathy. But study says ki there is no evidence of any benefit due to because of these agents. Now, how the patient should be treated? Treatment algorithm. So we will assess comorbid conditions, side effect potential, and the cost factor. Comorbid conditions patient has CHF, patient has already a seizure disorder. So we have to look into that aspect. So we can choose any of these four agents as a monotherapy, pregabalin, duloxetine, TCA, amitriptyline can be used, or nortriptyline can be used. Sodium channel blockers. Now, what are these comorbid condition and which agent we should prefer out of these four agents? And now this is a update key in the latest edition of Harrison. You might be reading that only two agents are the initial agent of choice for diabetic peripheral neuropathy, but the recent guidelines says that four agents we can choose from. So comorbid conditions and prefer agent. If patient has mood disorders like depression, so obvious choice will be tricyclic antidepressant or SNRIs. Sleep disorders, again, same agent we can choose because they have more effect of drowsiness, seizures. Obvious choice will be we give sodium channel blockers. Like if patient has seizure disorder, we will give valproate in those agent, or we can give gabapentin. Now, if certain comorbidities are there, which agent should we avoid? Urine retention, TCA should be avoided because of its anticholinergic side effects. Constipation, avoid TCA. Orthostatic hypotension, avoid TCA. Patient has extreme fatigue, SNRI should be avoided. Patient is a case of CHF, so we should avoid gabapentinoids because they cause edema and worsen heart failure. Now, we will look for the response. The response will be in terms of pain relief. If there is no meaningful response at 12 weeks, we will add agent from the other group. Like if we have given pregabalin, then we can add duloxetine, or we can add TCA. So double agent will be given. Then we'll see if there is no response. Then we will go for opioids or local agents in these patients. But try to avoid triple therapy of these agents. Means ki double therapy of two different classes of agent is more preferable. Also avoid giving TCA along with the SNRIs. These combination should be avoided. So we can give a combination of pregabalin with duloxetine, pregabalin with TCA agents. Like that we can choose. Similarly, avoid giving pregabalin with sodium channel blocker because of the similar sort of actions here. So sodium channel blocker can be combined with duloxetine, like that. Now, if a patient has no response even with the local agent, then we have to refer the patient for pain clinics, specialist pain clinics. So this was about the management of diabetes neuropathy. If you have any doubts, any queries, any question, you can put in the comment section. Thank you.